I hope I'm audible. And let me introduce myself. I'm Subhashini. I've done my PG in oral medicine and radiology from Government Dental College, Bangalore. And I just want this to be a slightly interactive session. So please feel free to unmute and just ask any questions or um, any doubts that you have. And please respond to the questions also. So we have, I think, around 10 or so students over here. So I'll so I'll just start off, and then maybe we can, when the others can join, they can join in. Am I audible? Can anyone please confirm? All right. Okay. I got your messages. Right. Okay. So this is also fine if you can just send a chat message also. I just wanted to be it's like talking to a wall and just want to avoid that. Okay. Right. So before I begin, just a few words. Now, you're all in your last leg of your preparation for this year's NEET. You have just a couple of months left, isn't it? So you must be quite thorough with whatever you have already prepared for. So I'll be taking two sessions of medicine and radiology. So today I thought I'll start with radiology because it's a standalone thing, whereas medicine will be a little bit kind of, the questions are similar to oral pathology. So I'll start with radiology today. And what I've done is that I've put together a few questions from previous year's papers with the same choices that were there in the previous year's paper. I've done it in such a way that I've taken one question from one chapter. So that way I thought the idea was not to discuss the question itself, but rather to discuss the background of that question. Okay. So any moment, like I said, anytime, please feel free to unmute and ask any questions that you have. Okay. So I'll start now. Okay. So if I ask a question, can you people send your messages by chat? I think then I'll have to stop sharing. Yeah, that'll be nice. Okay, that'll be nice. I don't mind, going stop sharing and restarting again. No issues at all. Okay, right. Okay, right. So here we go. So we'll go chapter wise, and the first question is like this. Um, the speed with which electrons travel from cathode to anode, this is in the X-ray tube, depends upon the potential difference between the two electrodes, the number of milliamperes in the tube current, the angle between the filament and the target, and the voltage of the filament. If you've read the question, I'll just pause now. Can I have your answers? Okay. Right. Fine. Fine. Okay. Perfect. So what I thought is like the power supply of a tube is what is usually confusing in this chapter. So I'll just go over the briefly the power supply of the tube. Okay. Yeah. So I think you know this, but let me just go over it again. Okay, so this is our X-ray tube. There's a cathode and the anode. This is one circuit over here, and this is another circuit here. Okay, so we have two transformers here. This is called as the step down transformer, and this is called as the step up transformer. The incoming voltage, as we all know, is around 230 volts in India. So as it comes down, the step down transformer will convert the 230 volts to around 10 volts, and that voltage will heat up this cathode. And the heat, because of the thermionic emission from the filament, the electrons are liberated, which go towards the anode, and from there the X-ray photons are liberated, right? So the second circuit is where we have a step-up transformer. So this will increase the voltage from 230 to about 60,000 to 70,000 volts to even 100,000 in case of extraoral machines and all that. We call it as kilovolts, 60 kilovolts and all that. Okay, so that is the voltage that is applied across the cathode and the anode. So higher the voltage, the higher the speed of the electrons from the cathode to the anode, which is what you people mentioned. Okay, so the milliampere measures the amount of current that is given to the cathode. Okay, and it tells us that the speed with which the number of electrons that are liberated from the cathode. Okay, so that will depend upon the X-ray photons that are generated will depend upon the number of electrons that are coming from the cathode. I have another thing here. Yeah, so this is, you already know, primary coil and secondary coil. This is a step up transformer, which will increase the voltage. The step down transformer will decrease the voltage. Okay. And we have a KVP selector dial, an MA dial, an MA selector over here, which will allow us to select the proportions for this. Okay. So any doubts with this particular concept of power supply of the X-ray tube? Right. Okay, so can I ask you a question out of this? So can you tell me, like, what does the total energy of the X-ray photons that are coming out of the X-ray tube depend upon? The energy of the X-ray photon. The highest energy and the total energy. Amy? Okay, no, ma'am. Is the question is unclear? Is the question not clear? Okay, I'll just go over it. See, the number of X-ray photons that are coming depends upon MA. The energy of the X-ray photons that are coming out depends upon the KVP. Just remember these two things, okay? The number of photons depends upon the MA, or the current that is given to the cathode, and the exposure time. We call it as MAS. It's a multiplication of the two. When you multiply the MA into the amount of seconds, you're going to get, that is going to be directly proportional to the number of X-ray photons. Whereas the energy of the photons is directly proportional to the KVP. Higher the KVP, higher the energy of the mean energy as well as the maximal energy of the X-ray photons. I hope this much is clear. I'll go on to the next. Yeah. So second question. So a patient with a history of radiation therapy requires special consideration because plaque accumulation greater than normal can be expected. Salivary function may be increased, the vascularity of the bone may be disrupted, and the potential for periodontal disease is greatly increased. I think this is an easy question only. Correct. So everyone has answered it as C. Correct. Okay. So I'll just go over that basics. So when the bone is irradiated or when there is any irradiation to the maxillofacial structures, the bone marrow is replaced by a fibrous tissue or a fatty marrow, and the marrow becomes these three H's. I think you all remember this. Hypoxic, meaning having less oxygen, hypovascular, having less vascular supply, and hypocellular. That means the osteocytes that are present will be reduced. So because of all this, the bone is in a compromised state. So this is till one state. This is the state of the bone. Now what happens? A second thing that happens is an event. An extra event has to occur. This event could be an extraction that is performed, or any irritation from say from a denture that the patient wears, or an infection from a periapical infection or a periodontal infection, something like that into the bone, an infection that is extending into the bone. Now because of this superimposed event, we already saw that the bone is compromised. The bone is not able to heal itself when such an event occurs. So because of that, what happens? There is spread of infection into bone, and that causes bone death. Because the bone is not able to heal itself, there is death of the bone and exposure of the bone, and this is called as osteoradionecrosis. So there's necrosis of bone secondary to the radiation therapy. So this is just to give you a clinical, this is what an osteoradionecrosis looks like. So the part of the bone is exposed here into the oral cavity. It's an extremely painful condition. And this is the moth-eaten appearance that you see in osteoradionecrosis. Okay. Any doubts with this question? Yes, Sayan, is it? Please unmute yourself and ask the question, no? I haven't gone to the next question. Just 1 minute. We are still in the previous question. Sorry. Yeah. Is there any doubt with this? Is there any doubt with the osteoradionecrosis question? No. Oh, is it? Okay. No issues. Fine. Okay, then we'll go on to the next question. I think osteoradionecrosis is like handled so many times in so many exams, and also you people must be really thorough with it. Okay. So which of the following is the least radiosensitive tissue? WBC, bone cells, epithelial cells, muscle cell, nerve cell, bone cell, connective tissue cell, endothelial cell, muscle cell, RBC, muscle cell, and nerve cell. Look at the options carefully and then answer. I got one B. Vedashri says D. I got 2D and 2B. So slight controversy here, I think, right? Okay. Oh. Yeah. Okay, so this is a chart which you're all familiar with. We'll go over this and then go back to our choices. Okay, so the radio sensitivity of the cells is divided. All cells in our body are divided into 5 groups. The first one are the vegetative intermitotic cells, differentiating intermitotic, then multiple. Basically, cells which are continuously dividing and which are totipotent, meaning they are not differentiated. Then we have some differentiating cells which have some amount of mitosis taking place. Then we have the multipotential connective tissue cell, reverting post-mitotic cells which have differentiated already, and fixed post-mitotic cells which are have achieved the highest level of differentiation and will no longer divide further, isn't it? So the radio sensitivity keeps increasing from here to here, meaning these are the least radiosensitive and these are the most radiosensitive. Yes, Meena. Do you want to ask a question? Okay. Okay. Right. So I was telling you that radio sensitivity increases from here till here. That is, see, two things we have to remember. Is the cell undergoing division or not, mitosis or not? Then second thing, is the cell differentiated or not? If it is continuously undergoing mitosis, then it is radio sensitive. It is not undergoing mitosis, it is not radio sensitive. Is the cell differentiated? If it is differentiated, it is not radio sensitive. It is undifferentiated, it is radio sensitive. Keeping these 2 points in mind, we'll go back to the question. This is somehow going backwards. Yes. Okay. Now we look at all these choices. WBC we know is a differentiated cell. It will not divide. So obviously it is not radiosensitive. So the question is least radiosensitive, isn't it? So it is less not radiosensitive. But bone cells keep dividing. We know that when they say bone cells, they mean it could be osteocytes, osteoblasts, anything. They've just told the term as bone cells. And in the previous question only, we saw what happens in bone. There is death of bone, the bone becomes affected and all that stuff, isn't it? So bone cells are sensitive. Epithelial cells is again, it's a very broad term. So epithelium consists of, the various layers of epithelium, and the basal cell layer is very, very sensitive. So this is definitely not the correct answer. Next, muscle cells. Muscle cells are differentiated and not radiosensitive. Nerve cells are differentiated and not sensitive. Correct. But what about bone cells? They are different. They are differentiated, but they are radio sensitive. So this answer is not correct. Connective tissue cell is a fibroblast which is moderately differentiated, but it can undergo division when required. So it is radiosensitive. Endothelial cell is definitely radiosensitive. It is one of the most radiosensitive cells. Muscle cell is not radiosensitive. So this answer is also not correct. D, RBC. RBC does not even contain a nucleus, so it cannot divide. So it is not radiosensitive. Muscle cell, highly differentiated, will not divide. Nerve cell, highly differentiated, will not divide. So all three are true in this. So this is the correct answer. So D is the correct answer. Is this clear? Any doubts? Uh, yeah, right. Okay. I'll just go back and yeah. Shall we go on to the next question? Okay. Now, a low kilovoltage technique is most advantageous in demonstrating resorption of alveolar crest, periapical lesions, incipient caries, and nutrient canals. So we are talking about a low kVp exposure in a IOPR. What do you think is the correct answer? Low kVp when we give, what happens? No answers? No answers? I've not got any answers so far. Not sure? At least tell me if you're not sure or something. No issues. I'll explain what it is to you. What happened? Yeah, please, please do, please. A and C confusion. Oh, okay. I was not getting the chat for some reason. Okay. D, A and C confusion. Okay, D. Sorry. For some reason, I was not able to see the chat. So I was wondering what happened. Okay. Uh, what is this? Periapical lesion? Chandani, is this for which question was this? Yes. No, not in the object. Not in the object. In the film. Large difference in density in the object. Sorry, in the film. Okay, I'll do one thing. I'll show you an image that will make it very clear for you. What do we mean by a... Okay, right. Now this picture, you all please stick it into your memory. It's very easy to remember. The KVP goes on increasing from here to here. When we look at the gray scales, we call these as the gray scales. The gray scales also keep on increasing from here to here. Okay, means at 100 kVp, I can see so many different grayscales, whereas at 40 kVp, I can see very few grayscales. Like till here to here is almost completely black, and from here it's completely white. So in between some 2-3 different shades. Whereas here I can see shades of black, slightly lighter, lots of shades of gray. So uh, so this is called as the short grayscale because we have fewer number of grays, and this is also called as the high contrast. Why it is called high contrast is because we are able to differentiate a completely black area from a completely white area. Whereas here, there are in between the completely black and the completely white area, there are multiple shades of gray. So this is called as the long grayscale or low contrast. So if you remember these words, low contrast and high contrast, it is opposite of this. That is how you can remember low KVP, high contrast, high KVP, low contrast. Just keep those two things in your mind. Now, when we take a radiograph with this kind of an image, okay, so depending upon the KVP that we have given, we might get a film, an X-ray film, which has something like this, like, a high contrast image where it's very clear, there are black areas and there are white areas. Okay, we prefer this kind of an image for detecting things like incipient caries. Imagine that there is a proximal incipient caries, because that incipient caries will still be in enamel, and enamel we know is highly radio opaque. So in that radio opaque structure, small bit of radiolucency, we will be able to see it in this. We'll be able to see it as only a slight gray shadow in this kind of a contrast. That's the reason for incipient caries, we prefer a low KVP. For periodontal conditions, for periodontal bone evaluation, because there is a buccal cortical plate, lingual cortical plate and all that, for that we prefer a high KVP and a low contrast. Is this clear? Is it confusing or clear? Okay, Mansi wants me to repeat it once. I'll just briefly repeat it once. Okay, so Just remember this picture. Here we have fewer shades of gray. Here we have more shades of gray. And the KVP goes on increasing. This is called as a long gray scale because multiple gray shades are there. High KVP, long gray scale. Low KVP, short gray scale. Okay. Or high KVP, low contrast. Why it is called low contrast is not much difference between the individual grades. Whereas here there is a lot of difference. From here to here there is a clear cut difference. That is why this is called as high contrast. Low KVP, high contrast. High KVP, low contrast. You remember it that way. It's very, very easy to remember. Does that answer your question, Mansi? Mansi, is that clear?
Yes, ma'am.
Right, thanks. Okay, so if this is clear, we'll go on to the next question. Film exposed to light during developing will be blurred or dark or light or reticulated. Correct. So easy question. Yeah, everyone has answered correctly. The answer is dark. Okay. So just going over developing process again. So this is, I don't know if this is very clear, this is clear for you or not. So this is a normal image IOPR, whereas this has been exposed to light. So you can see the darkness in this image. So this part of the image is not visible at all. So that is because of exposure to light. Okay. So the same thing here also. So this is exposure to light, and we can see that, we're not really able to differentiate the difference between enamel and dentin, whereas here you're able to so clearly you're able to make out the trabeculae and all, whereas this image is not a very nice image. So I think you know this. Every film contains, what are these crystals called?
Silver halide crystals.
Silver halide crystals. So, and they get converted into neutral silver atoms. So the entire crystal becomes a neutral silver atom when it is exposed to the X-ray or to light. The film is also sensitive to visible light. So let's say, for example, this film was exposed only to X-ray. So you have fewer crystals which have become completely black, whereas this has been exposed to light also. So there are more crystals which are completely black. That's a simple reason why film, this is just a very, schematic sort of a representation. Very few crystals have shown. There are millions of crystals in a single film. So because of this, the image appears to be darker when it is exposed to light. I'll go on to the next question. The rare earth elements used in intensifying screens which emit green light are yttrium tantalate, niobium activated, gadolinium oxysulfide, terbium activated, yttrium tantalate, terbium activated, and gadolinium oxysulfide, niobium activated. B, C. Good. Okay. Most of the answers are B, and B is the correct answer. So for this, I'd just like to tell you, you can just by heart it itself. I'll just show you a diagram which will help you. But these kind of things, just keep it in mind that gadolinium is combined with terbium only, and this gadolinium oxysulfide, terbium activated, is what emits a green color light. So you all know what an intensifying screen does. Composition of an intensifying screen, just to go over the basics. So it consists of a base which just provides a support to the rest of the layers. Then we have a reflecting layer made up of titanium dioxide, which reflects the light which falls upon it. And then we have the phosphor layer. Phosphor layer converts the X-ray photons into visible light. And then we have a protective layer. So out of these phosphor layer, earlier they used to make it out of calcium tungstate, and calcium tungstate used to always emit blue color. Nowadays we have rare earth screens which use a rare earth material. So these rare earths, gadolinium oxysulfide emits a green color, lanthanum oxysulfide emits a green color, lanthanum oxybromide emits a blue color, yttrium tantalite emits a blue color. So this is just for your information. I mean, you'll just have to by heart it, I guess, because I mean, that's the easiest way to remember it. Okay. And only thing to remember is that when we have an intensifying screen, which is a green emitting screen, your film that you're placing in the intensifying screen has to be green sensitive film. That's all. Okay. Next question. Overlapping of proximal structures in periapical radiographs is due to incorrect horizontal angulation, incorrect vertical angulation, improper orientation of the film, and patient movement. Again, easy question. Yeah, correct. Right. Good. So this is easy, and you've all seen this. Okay. So just have a pictorial representation of this. So if the PID is there, your central ray should be perpendicular to the contact areas of the teeth so that there is no overlapping. Whereas if the rays are at an angle in a horizontal plane, then we get this overlap, this kind of a radio opaque structure between two teeth. So this is called as overlapping, right? So this, I think you all know about it. How to correct it is just to correct the angulation, the horizontal angulation of the film. Okay. In a pantomograph, if patient chin is placed anterior to the focal trough, the structures appear to be blurred and diminished, blurred and magnified, either magnified or diminished, and only blurred. Shyam, previous question is which one? Just one moment. Shyam, which one? The horizontal overlapping one? Intensifying screen one? Yes, yes. The answer is B. Gadolinium oxysulfide, terbium activated. Right. Blurred and diminished. Okay, A, I got 2 answers. Correct. Correct. Blurred and diminished. Right. Okay. Okay, so here we have a pictorial representation. So this is the bite block where the patient is supposed to bite, and this ring is the what we are going to check. So when the patient is correctly positioned, all we have to remember is that the focal trough is very narrow in the anterior area. So when the patient is correctly positioned with the bite block, then the ring will be correct in size. If the patient is too posteriorly positioned, then the ring is going to become wider. So if your question is that the patient is backwards, then your teeth are going to be horizontally magnified. If the patient is placed anteriorly, forward placed, then the ring is going to become narrow, meaning the teeth are also going to be narrowed down in the anterior region. Just remember that in the posterior region, the teeth are not much affected. It is only the anterior region that the focal trough is very narrow, and that's why this is a very sensitive zone. Right. Next question. Best radiographic view for condylar and ramus fracture. Caldwell view, Towns view, reverse Towns view, and Waters view. Two C's, reverse Towns. Correct. C, C, C. Okay. Okay. Fine. Correct. So all of you have given C only, reverse Towns view. So just have a look at what these particular radiographs are. So this is, I'll just give you the indications for all of them also. This is the Caldwell view. Okay. The Caldwell view is mainly taken for the frontal sinus. Okay. And the other sinuses. I mean, mainly the frontal sinus. Just remember that part. I'll show you the positioning in a moment. This is the Towns view. So these are all PA views wherein the anterior part of the skull is seen very clearly, whereas the Townes view is an AP view. AP view meaning the X-rays go from anterior to posterior. So if you look at, this is the Townes view and this is the reverse Townes view. So these two you can see the difference. So here you can see the skull very clearly, whereas here you can see the maxilla and the mandible very clearly. So this patient is placed backwards, that's all. So this is Townes view, this is reverse Townes view. So here you very nicely we can see the condyle and we can also see the ramus. So that's why, in fact, there is also a condylar fracture here, which is medially displaced. And this is the Waters view or the PNS view, which is typically taken for the maxillary sinuses. This is the positioning for the various views. So the Waters view, so like I told, it's a PA view. Patient is looking upwards, 37 degrees. The canthomietal plane. The PA skull view, patient's nose is touching the cassette. Reverse Townes view, patient is looking downwards, canthomietal 30 degrees below the occlusal plane. Submento vertex is an AP view, in the sense it's a inferior-superior kind of view, where your Frankfurt horizontal is perpendicular to the floor, and the X-rays go from below the chin, submento vertex, from below the chin to the vertex. Lateral ceph, you all know, where the patient is, where the film is placed lateral to the left side of the ear, or the left ear of the patient. Okay, so Waters view, the main indication is for the maxillary sinuses. It's also a very good radiograph for the coronoid process fracture. PA skull is a good view for comparing the right and the left sides of the skull. Reverse Townes view, like you all told, is a very good radiograph for the condylar fractures. Submento vertex view for base of skull, and zygomatic arch, any zygomatic arch fractures. Lateral ceph mainly for orthodontic purposes. Yeah, and the Caldwell view. Caldwell view is patient is looking slightly downwards, like I told you, it is for the frontal sinus. So are these views clear? Okay. Submento vertex view. I'll just repeat submento vertex. So submento vertex is the patient is stretching the neck backwards. See, the name of the view itself indicates the direction of the X-rays. In this, all these cases, just remember, when we say PA, means X-ray goes from posterior to anterior. Similarly, in submento vertex, sub is below, mento is chin. So below the chin, the X-ray travels from below the chin to the vertex of the skull. So in this direction. The Frankfurt horizontal plane is like this, perpendicular to the floor and parallel to the cassette. And the canthomietal plane is like this, like, it is 10 degree beyond the vertical, we say, like this. So how do I put it? It's like the patient is bent further beyond the vertical plane. So that is the submento vertex, the positioning. And the main indication is the zygomatic arch fractures, because of the positioning of this particular patient positioning, the zygomatic arch comes outside the skull and we are able to visualize it very well. Does that answer your question, Shyam? Okay. Right. Okay. Okay. So next, we'll go on to the next question. Okay, onion peel appearance on a radiograph is not seen in Gary's osteomyelitis, Ewing sarcoma, osteogenic sarcoma, and fibrous dysplasia. Very good. Getting all correct answers. You're all really well prepared, or I've put very simple questions. I'm really not sure. Nice. Yes, fibrous dysplasia is the correct answer. So these are some images of onion peel appearance that I got for you, something like this. And we all know that fibrous dysplasia doesn't consist of any, it just consists of ground glass appearance, no onion peel appearance. All the others have this. Yeah. Okay, since it's clear to everyone, I'll go on to the next question. Foreshortening of the image occurs when the central ray is perpendicular to the film, but not the object, directed at an angle more positive than perpendicular to the bisector, both of the above and none of the above. So I'm getting all the three choices here. Some are saying A, some are saying B, and some are saying C. Both, that is C. Okay. So some confusion in this question. Okay, let us look at this question now. So which technique of IOPR are we talking about here? There are two techniques of obtaining IOPR, isn't it? Which technique are we talking about here? Correct. Bisecting angle, isn't it? Okay. Now, in which technique is the X-ray photon, the X-ray beam perpendicular to the film? In which technique is that correct? No? Yes. Paralleling technique. Yes, correct. Correct. Right. Right. Okay. Fine. See, can you see me here? Okay. So in paralleling technique, because I haven't put a diagram, I'll just, so if this is your film, your X-ray beam is going to be exactly perpendicular to both the tooth as well as the film. So that is the paralleling technique. Whereas in the bisecting angle technique, what we do is you have, this is the bisecting angle technique, you know, it is based on that Ciesinski's principle and all that. So this is the X-ray beam, and the X-ray beam is perpendicular to the bisector of this angle that is formed between the long axis of the tooth and the film, right? So this bisector we have to imagine and make the X-ray perpendicular to this bisector here. Why we do this perpendicular and all this circus is so that the length of the tooth which is there here is the same as the length of the image upon the film. So that is the idea behind this bisecting angle technique. And you all, as you all know, most of us in our colleges and all that in India, we often practice this bisecting angle technique itself. Okay. Now let's look at this diagram. Now let us assume this yellow line is showing us the correct angulation of the X-ray beam, the correct vertical angulation which is giving. So I know it is a bit long. Please imagine that it is the same size as the tooth. Let us say I take an angle which is more than this, but this is your correct vertical angulation. If I take a slightly higher angle, yeah. So now this angle, instead of giving that plus 40 degree, I've given now plus 50 degree. So this is a higher angle. So because of this higher angle, what has happened? The image of the tooth, with the tooth length is so much, whereas the image of the tooth is only so much. So what happens is that your tooth, the image of the tooth has become smaller. So it has become foreshortened. On the other hand, if we take an angle which is smaller than your actual angle, we've taken, let's say, plus 25 or plus 30 degrees, then your image of the tooth is going to be from here till here. So it is a longer image. So shorter the smaller the vertical angulation, longer the image. Higher the vertical angulation, shorter the image. Keeping this in mind, we'll go back to the question. Yeah. So perpendicular to the film, but not, my cursor is not coming here. Oh. Yeah. Yeah. So perpendicular to film, but not object is not a choice at all, because it is a theory behind the paralleling technique. Directed at an angle more positive means instead of plus 40, it was plus 50 than perpendicular to the bisector. Perpendicular to bisector is the correct angulation which we gave. Suppose we gave a more positive angle. That is, instead of plus 40, we gave plus 50. Then what would happen? We would have foreshortening. I hope this is clear. So this B is the correct answer. Please confirm whether this is clear to you. Yes, B is the correct answer. Both, is it? So you're by hearting from Pulse, is it? Okay. 1 minute, then I'll just go over it. Perpendicular to the film, but not object. I'll just go over it. 1 minute. So perpendicular to the film meaning, okay, it'll come somewhat like this, I guess. Okay, yeah, I guess that also would be correct. In this particular diagram, at least it is correct. Okay, then I stand corrected. Then I think C should be the correct answer. You're right. So in both the conditions, yes, it would cause. But I assume that perpendicular will not happen in bisecting angle. No issues, correct. So if it is perpendicular, you have to imagine it like this diagram and then say that it is definitely causing foreshortening. Okay. So the correct answer will be C. I'm sorry about that. No, no, no. In elongation, angulation is less. When you give less angulation, there is elongation. And in foreshortening, angulation is more. Correct, correct. What is the doubt? Mumina? Correct. The option should be both. You're right. So the answer is both. Answer is C and it is both. Any further doubts in this? No, right? Okay, fine. Okay, that's right. Good. Oh, okay. One moment. Okay. A non-vital asymptomatic tooth with a deep carious lesion shows radiopacity at the apex, which is possibly a cementoma, a condensing osteitis, periapical cyst, or periodontitis. Again, a relatively easy question. Yes, Vedashri, you want to say something? Okay. Okay. So this is quite clear, I guess. I'll just close this. Yeah. Okay. So I just put some images for you to remember. So this is a vital, sorry. This is a vital tooth with a radiopacity at the apex, which is a cementoma. This is condensing osteitis, a non-vital tooth that is a large carious lesion involving pulp with a radiopacity at the apex. So this is a periapical cyst. Obviously, it is not a radio opacity; it's a radiolucency. And periodontitis, definitely, these two are not applicable at all. Okay. Which of the following lesions is often multiple and distinguished from periapical abscess by their association with vital teeth? Hypercementosis, periapical cemental dysplasia, myxofibroma, peripheral ossifying fibroma. Which one occurs only in children, Shyam? Condensing osteitis? No, not necessarily. But in younger individuals, yes. In younger individuals, because the bone can respond more, no? So definitely it is more in younger individuals rather than in older individuals, and slightly, chronic carious lesions, which have been there for a long period of time and all that. I hope that answers your question. Right. So, yeah, so this everyone is clear, periapical cemental dysplasia. Okay, so this is hypercementosis, and hypercementosis is generally, most commonly it's associated with the non-vital tooth, because it is the infection that is there in the pulp canal or the periapical region is what stimulates the hypercementosis. This is multiple radiopacities at the apex in vital teeth. So this is periapical cemental dysplasia. This is a myxofibroma, which is a completely radiolucent lesion. A peripheral ossifying fibroma is actually a soft tissue lesion. It will be something like this, it will be like firm in consistency. And actually we will not be able to see any radiographic feature. If you take a radiograph, it looks absolutely normal. They have just taken one more perpendicular view to show this. There is a soft tissue swelling and small spicule of bone over here to show that it is an ossifying fibroma. Okay, so these are just some pictures for you. Yes, periapical cemental dysplasia is seen typically in anterior teeth. You're right. Okay. Shall we go on? Yes. You want to ask something, Vedashri or Omina? Omina, please raise your hand. Sorry, please unmute yourself and let me know. Okay. Okay. Okay, then I'll go on. Ellis cysts are a feature of osteoarthritis of TMJ, chronic suppurative osteomyelitis, fibrous dysplasia, peripheral ossifying fibroma. Yeah, so this is again quite clear. So this is what an Ellis cyst looks like. Basically, an Ellis cyst is not a cyst. Please remember this. It is not that it is a fluid containing thing or something. Basically, our osteoarthritis is a degenerative joint disease, meaning there is destruction of bone that is happening. So when we take a radiograph, it looks like as though there is a radiolucency within the condyle. So because of that destruction that is happening in a different plane, it looks like radiolucency is inside the condyle, and that's why they thought it was a cyst. So just remember that one point, that this is not a true cyst. It is just a destruction of bone, just a degeneration of bone. Your other choices, a chronic suppurative osteomyelitis causes a moth-eaten appearance, fibrous dysplasia, ground glass appearance, and peripheral ossifying fibroma we just saw in the previous case. It will show, it will not show any radiographic features. Best imaging technique to view TMJ derangement is MRI, CT, pantomography, and PET scan. Okay, right. Why MRI? Why MRI? Correct, soft tissue. Why not CT? CT is mainly for what? Disc is soft tissue, perfect. CT is for hard tissue. OPG, again, it's hard tissue, so it is not seen. What is PET scan? Why not PET scan? Yeah, it is positron emission tomography for secondaries in cancer they have seen from small tumors. Okay, PET scan is basically to detect any secondaries, to detect any metastasis from the major lesion elsewhere, any distant metastasis. So basically, a radiopharmaceutical drug is given to the patient, injected into the patient, and there is a gamma camera which will capture all the positrons that are emitted from that area. So that will enable us, and it will be seen as a hot spot. I don't know if you've heard of it. It's a hot spot, and nowadays they combine PET with CT or MRI also. It's called as PET CT or PET MRI. So when we add the two, PET plus CT, it gives a very, very accurate. Now you're also telling that it is 2 mm, more than 2 mm and all that. No, we will not know exactly where it is with only using a PET scan. When we combine it with a CT, you'll be able to see clearly from where that hotspot is coming. So that combination is called as fusion imaging. Okay. So this you told me. Okay. Again, I took this also from Pulse only. So given, because I just wanted to see the quality of the images that comes on your question paper may not be great, but you need to identify the defect in this. So in this particular question, it might be you have read it so many times and all, but you'll come up with something new there, no? So that you should be prepared. So given radiographic image is suggestive of B, multiple punched out, regular punched out. Correct. Okay, all answers are correct. So you're all saying it is punched out radiolucency. So you should just observe this multiple radiolucencies. What do you see in Paget disease? Cotonal appearance. In Krausen disease? In Krausen disease, what do you see? Copper beaten appearance. Okay, correct. Maxillary protrusion, you all know. Okay, good. Very good. So here are a few images. So this is your cotton wool appearance of Paget's disease. Okay, so remember this, it's like wisps of cotton, more unilateral in this case. So this is actually one of our patients only. You have multiple punched out radiolucencies. Punched out radiolucencies because there is no radio opacity surrounding them. And copper beaten appearance, all these multiple, like as a copper has been like, there are multiple indentations in a metallic surface, something like this, and the thickening of the skull. Okay, next question. In which of the following types of digital sensors the image is read by transferring each row of pixel charges from one pixel to the next in a bucket brigade fashion? One B and one D. 2Ds. Okay, I'll explain this. Very simple for you to remember. Bucket brigade means CCD. That's all. Just remember that much. It's very simple. Bucket brigade means CCD. Just put it in your mind. That's all. You need not break your head as to what it is, but I'll just show you what it is. Now, what do we mean by this bucket brigade pattern? Okay, it means like suppose we have a series of buckets that are kept and there is some rain that is falling. Okay, now you want to transfer all the water that is collected in the buckets to one single bucket at the end. So what they do in bucket brigade is like each bucket will pour the water into the next and the next and the next like this, and this into this last bucket here. Similarly, each row will pour like this, and then the column, this last column will come out like this, and all the all the water gets collected over here. This is called as the bucket brigade pattern. So why we call it like this? In CCD, what happens? You have multiple pixels. So pixel is basically something like a unit of an image where just like our X-rays, in just like we have crystal, silver halide crystals in our X-ray film, like that only there is one pixel over here, which will like, take into account number of X-rays that are falling on that particular area. Okay, so it has collected a certain amount of reaction because of with that X-rays. That reaction is transferred from here to here to here to here, and then it is read out, something like this. This is the readout that is happening. So everything is transferred and then read out. So it is called as the bucket brigade pattern. Very simple. Coming to the other two, this is a PSP plate. Okay, so a PSP plate is a flexible plate. It is a reusable plate in which what you do, it's just like an IOPF film itself. You just place it in the oral cavity, take an image, and then you have a laser scanner. So you have to put the film into the scanner, and then this is directly connected to a monitor, and the image is visible on the computer. So that, and then you have to erase the image and then reuse the film. That can be done with a PSP plate. So this you have to remember that you need a scanner for this, a laser scanner for this. The third one is a CMOS sensor. CMOS sensor is very similar to CCD, but instead of bucket brigade, there is no bucket brigade in CMOS, whereas each pixel there will be a direct readout. Okay, from each pixel there is one wire that is connected, so there is a direct readout of the signal that is received at each pixel to the computer. That's all, and that will give us a image. Okay, so basic mechanism, is it clear for you? Correct answer is D, CCD. Okay. So these were the questions that I had prepared. So I had just taken one question from each, and actually I'd taken a little bit from Pulse itself. So there, some of them will be really familiar for you and also. So I want to know if there are any questions from your end. Okay, I can do that. Just 1 minute. I'll just find out if there are any other questions. Shyam, just 1 minute, okay? Anybody else, any other questions? Or any points that you have not understood that you want to clarify? Yeah, sure. Just 1 minute. That okay. I'll just go over the first few questions. The speed with which electrons travel from cathode to anode depends upon the potential difference between the cathode and anode. The higher the potential difference or higher the kVp, the faster the electrons. So the conclusion was that the energy of the X-ray photons that comes out from the anode depends upon this kVp. A patient with a history of radiation therapy requires special consideration because the vascularity of the bone is disrupted. I think this question was, everyone was quite clear with this. So this we saw what happens when there is irradiation, the marrow becomes hypoxic, hypovascular and hypocellular. And if there is a superimposed event such as an extraction or an infection, then there is bone death and exposure of bone. So this is what an radionecrosis looks like, where bone is exposed to the oral cavity. Which of the following is the least radiosensitive tissue? So here two things were important. One is the cell undergoing mitosis? If it is not undergoing mitosis, then it is not radiosensitive. It is undergoing mitosis, it is radiosensitive. Second one, is it differentiated? If it is a differentiated cell, it is not sensitive to radiation. So the correct answer was D, RBC, which is highly differentiated non-dividing cell, muscle cell, which is again highly differentiated non-dividing cell, and nerve cell, which is highly differentiated. So when you get questions like this, just analyze them very, very carefully. A low kilovoltage technique is most advantageous in demonstrating incipient caries. So here we discuss that low kVp means high contrast. So this is low kVp, and the contrast between the different grades, the shades of gray, is very, very different. This is why it's called as a high contrast. So this is a high contrast, and we prefer such high contrast films to visualize things like incipient caries. The low contrast film, the high kVp, if we give, there is low contrast or a long gray scale of contrast, and this is useful in periodontal bone levels, assessing periodontal bone levels. If a film is exposed to light during development, it will be dark because the film is sensitive to dark also. We saw how the silver halide crystals become converted to neutral silver when there is exposure to light. Rare earth elements used in intensifying screens which emit green light are gadolinium oxysulfide, terbium activated. This is the correct answer. Just remember this answer, that's all. Is that clear till here? So you asked for 6 questions. This is very clear. Overlapping of proximal structures. The chat is not opening. Yes. Okay. Bisphosphonate related osteonecrosis recently asked question regarding dose, is it? Dose of what? Bisphosphonate, is it? Okay. See, one thing about bisphosphonates, it's not dose related. Let me tell you that much about bisphosphonate, because the half-life of bisphosphonates is something like 10 years. So even if a patient is taking a small amount of bisphosphonate, it will get accumulated within bone, and there is a very long chronic period where a patient can develop a bronchi. Okay, so that is the thing about bisphosphonate. But if you can get me the values, then I will just do a check about dosage. I have to read up a little bit about the exact dose. I don't think, I think any bisphosphonate has a tendency to cause bisphosphonate related osteonecrosis of the jaw. This is my understanding, but I'll go over that once and I'll just clarify. Okay. How to remember all those values in oral radiology? Which values? The inherent and the added filtration values. Different books, different answers, is it? Okay. Inherent and added filtration, the government regulation is 1.5 and 2.5 millimeters of aluminium. Is it related to filtration? Or is it half value layer? Filter for a modern X-ray set is, okay, 1 minute, I didn't read this. The filter for a modern dental X-ray set is 1 mm, dental X-ray, no, 1 mm, 1.5 mm aluminium, 2 mm aluminium, 2.5 aluminium. See, anything that operates below 70 kVp, 1.5 mm is sufficient. Yes, 1.5 mm is the government regulation.